Hello and welcome everyone to the 41st episode of the official podcast of Indian Journal of Anesthesia. I am Dr. Amrita and it's my absolute pleasure to be your host for today's session. As always, we bring to you insights from the heart of academic anesthesiology, a space where evidence, editorial perspective, and innovation intersect. Today, we are joined by none other than Professor Rakesh Garg, the esteemed editor in chief of IJA, a passionate academician and a relentless advocate for scientific integrity and quality in publishing. Professor Rakesh' editorial insight has helped shape the IJ into a beacon of scholarly excellence, not just in India but internationally. In this episode, we will take you behind the scene of the latest issue, exploring the key publications, notable case reports, systemic reviews, and the cutting edge original research that challenge our clinical practice and inform our future directions. So, whether you are tuning it from your OT, your ICU, your research desk, or a well deserved break, stay with us as we unravel what's new, what's impactful, and what's coming next in the world of anesthesia literature. Professor Rakesh, thank you so much for joining us once again. It's always an honor to have you on board. Let's start with the highlight from this issue. What's caught your eye and why?
Thank you, Dr. Amrita Rath, and let us welcome you into the gang of IJ podcast. And with this IJ podcast, IJ is coming up with many good initiatives, spreading the knowledge beyond the limits, and its presence not only nationally but globally is giving a chance to all the listeners to understand the new upcoming knowledge in the field of anesthesiology, critical care, and pain medicine. And so is the issue for the May, which has been released and is available online. As you rightly said, that IJ do provides a good platform for all the researchers to publish their hard work so that the community as a whole globally can take benefit and improve the patient care. And so would be the May issue that we have today. In this, a special commentary is there. We all know that the segmental thoracic spinal anesthesia is a buzzword, though it was an old wine, but it is being served in a new bottle now with its new indications, new understandings, better understanding probably. And the author has published a commentary in which they have talked about how to use the thoracic spinal anesthesia, segmental spinal anesthesia for clinical cases. But simultaneously, it also needs to be emphasized that any new technique will have its limitation. It cannot be used blanket. Patient safety is paramount, and the patient selection is equally important. And hence, an editorial by the editor supports that commentary that the segmental thoracic spinal anesthesia beyond high risk cases are we ready for routine use. And I'm sure that the combination of both the editorial and the commentary will be quite useful to the readers, and they can select thoracic segmental spinal anesthesia appropriately for their patients, giving all the benefits, but simultaneously taking care of all the untoward events, or we can say any concerns which may affect the patient or the nitty-gritties, which is equally applicable for almost all the techniques that we use in anesthesia. And simultaneously, there are many articles which has been published in the May issue, which talks about regional anesthesia, general anesthesia in various groups. And this will bring about the better understanding, the better update in the medical science. To begin with, when we talk about ketamine, we understand ketamine is an old drug. It is being used for newer modalities, newer indications, newer ways, and we need to understand whether it is really useful or not. When we talk about ketamine, an interesting meta-analysis is published by authors where they talk about intravenous ketamine on post-operative sleep disturbance, and we understand that sleep deprivation for many reasons, maybe pain, maybe anxiety, and other factors, do affect the outcome of these patients, increasing the length of hospital stay, increasing the chances of delirium. And hence, we need to have strategies so that these patients are comfortable post-operatively. And in this, a meta-analysis has looked for the various effects of perioperative intravenous ketamine on postoperative sleep disturbances. And the authors have concluded that administering ketamine during perioperative period can improve the postoperative sleep quality. I think it's a big event, and we also know that ketamine has an analgesic effect, which is definitely required in postoperative period. And I'm sure that this meta-analysis will be useful. All the readers can go through them and look for. We also need to understand that in education, in anesthesia training, and I was taking basic medical education for newly recruited assistant professors just 3 days back. And we were discussing that it becomes important during training not only to teach them what we know, train them for skills, and give them or transfer the information to them. But it also becomes important that when we teach them, we have to give them a feedback. How this feedback features during clinical education for anesthesia training, an interesting scoping review is there into the May issue of the IJA. And moving on, when you talk of pediatric patients, we usually talk about the safety during the airway management. We have been using different type of tubes, which we have been using different type of introducers. And when we talk of the head and neck surgeries, and we talk of surgery like cleft lip palate in pediatrics, definitely it's a airway challenge, not only because of the age group, that is children, but also the airway difficulty. And hence, use of oral microcuff RAE tube with and without FROVA intubating introducer, do they have effect? Let's see, or you see it yourself in the IJMA issue. And you will find that there is something interesting which has come up. Moving on, another interesting study. There is a buzzword called opiate sparing, opiate free anesthesia. And there have been a lot of controversies that do we really need opiate free anesthesia? What we need is a pain free patients, and hence we need to use it appropriately. But let's see this important study which comes from the authors doing surgery on endoscopic nasal surgeries. And they have used various techniques to use very sparingly or so called opiate free versus opiate anesthesia. And they have tried to look for the quality of recovery. Yes, we understand analgesia is important technique, analgesic management is important, analgesic score is important, but equally important is quality of recovery. So have a read on this, whether opiate free versus opiate anesthesia do have impact on this. We also talk about various blocks. They are becoming buzzwords now. And when we talk about various blocks for surgical procedures, they have become an inherent part. When we talk about balance analgesia, yes, we need to give certain blocks. And same would be, I talked about the airway management. Another interesting study, children with palate surgeries. They talked about whether intranasal transmucosal sphenopalatine ganglion block, do they have some opiate sparing action? And it becomes important in children where we want to give them opiates little cautiously so that they can have a better recovery, but simultaneously a good pain relief, and hence the blocks are important. And the authors concluded that sphenopalatine ganglion block causes a significant reduction in intraoperative fentanyl consumption. And in fact, it also stabilizes hemodynamics and facilitates smoother recovery. What more do we want from anesthesia? Read this article, get an insight, and improve your patient care. Similarly, many other articles are there which are related to various aspects. Another blog. Now, everybody of us are getting very fascinated about newer blog, and it becomes fascinating to me also that many people, including Dr. Amrita here, they are involved into coming up with newer blocks, newer indications of block, modification of block. Facial plane blocks are becoming so popular, and the regional anesthesia enthusiasts are trying to find the facial planes at multiple places so that they can block as per the requirement. And hence, this issue also has a study where they have compared ultrasound guided subpectoral intercostal plane approach and pectoserratus plane approach for intercostal brachial nerve block in patients undergoing surgeries of the upper arm. Again, the authors have found no doubt that these blocks are important, and they have concluded that the subpectoral intercostal plane block at second rib produces a faster and more complete block of intercostal brachial nerve in patients as compared to pectoserratus plain block at the fourth rib. Yes, these type of studies are coming up. We need more robust data to prove superiority of one block or the other. And not only the superiority, but it also needs to be defined that each block has its limitation based on the dermatome supplied by specific nerves and the nerves that are bathed in those fascias which are being flooded with the local anesthetic agents. We also need to understand that whether all the nerves which supplies that particular area for that particular surgeries are going through those fascias and how much or how much volume can be looked for. We have talked earlier that though we say it ultrasound guided block for any of the facial planes, but actually they are not completely ultrasound monitored because they guide the needle to reach the facial plane, but they do not see the spread of the drug in complete fascia. And hence, we also need to look for nomenclature, and this is a food for thought for all regional anesthesia enthusiasts and for future studies. Is it enough for facial plane blocks to see the tip of the needle into the facial plane? It's not one side, it extends up and down, anterior and posterior. Is that sufficient to look for the amount of drug that have injected? Have they bathed all the nerves in that fascia? We need to have the extension of ultrasound assessment of the spread in those fascias also. Though they have mentioned in this, it is beneficial, but I think future research should also look into this aspect that how ultrasound can be used to look for the whole facial plane for that particular block to lick, whether it has been taken care or all the nerves or all the plane is totally bathed with the volume that we do for, say, ultrasound guided brachial plexus block when we say that the local anesthetic agent has taken care of all the brachial plexus nerves which are there and they are fully bathed. Same thing has to be done for facial pain. We have discussed in detail earlier in our previous broadcast, and same needs to be looked for further on. Many of these facial pain blocks were for non-cardiac surgeries, but we have an interesting article for cardiac surgery and that too pediatrics. Many interesting pediatric articles, a good issue for pediatric enthusiasts. Here, the authors have talked about the efficacy of ultrasound guided single level pecto-intercostal facial plane block for postoperative analgesia after sternotomy. We understand that sternotomy is a very painful procedure. In pediatric, it becomes more complicated because the pediatric patients may not be able to do chest physiotherapy, incentive spirometry, and other lung recruitment maneuvers, and hence not giving them much of opiates, but simultaneously giving them a good pain relief using the safer blocks becomes important. And the authors have that's why found from this study also that single level ultrasound guided block provides good analgesia and hastens recoveries. And I think it's important, and even the cardiac anesthesiologist should also understand and try to include into their clinical management about these newer pain blocks which are giving beneficial to these patients. Another study which has come up for subtransverse interligamentary block versus erector spinal block for patients undergoing MRM. MRM to begin with, it was PEX block and then it proceeded with many other blocks that was entered into the armamentarium for facial blocks, plain blocks for the breast surgeries. And another element which has compared that which block is better than the other. Each block has its own limitation because the dermatomal area covered by a particular fascial blocks is restricted by the type of surgery. So if it's a modified radical mastectomy, it requires a broader involvement, and hence they have been always a lacuna to find an ideal block. Probably this study comparing these two block, subtransverse interligamentary block versus ESP, which has become I will not say the standard of care, but yes, mostly people have been using them. And they found that the still block is associated with lower pain scores, decreased postoperative opiate consumption as compared to the ESP block. People has been using ESP block. Probably PAX block is somewhere going not so popular, but let's see whether ESP will be replaced by near blocks. More study. And I will ask the researcher community to have meta-analysis on this issue also to come up that which type of breast surgeries, which blocks remains the best. We need to have more data, more research, probably a meta-analysis, a sufficient study are there, and this study will add on. Equally important is the use of hemodynamic monitoring. And when we say hemodynamic monitoring, it is important for critical patients, especially when we talk about kidney transplants, where the perfusion remains very, very important. Any incidence of hypotension in these patients can compromise the recipient kidney. And hence, it is not only a good management to prevent the hypotension, but why not to use equipment which can predict it? And that's why the equipment that are available into the commercial market, the hypotension prediction index, whether it impacts the hemodynamic management on intraoperative hypotension and kidney transplants are interesting, though a retrospective study, but interesting one where authors found that HPI provides superior intraoperative hemodynamic management in kidney transplants, which are high risk. So these were the patients who were having cardiac disease, dilated cardiomyopathies. But we also need to look for that using these type of equipments, whether they have really impacted on the long-term outcome of these kidney recipients. Though they have mentioned about the intraoperative period, but let's see whether these incorporating into the routine patients management for kidney transplants or maybe other transplant, will they affect on the overall outcome of you can say the acceptance or the kidney functions in the post-operative period for long period. This is further studies can be done based on this article which has been published. An interesting observational study, probably a cross-sectional studies. When we talk about understanding how people are practicing, it becomes important to understand the people practices which has varied experiences. And an interesting study coming from India where the authors have mentioned about the anesthetic practices in non-operating room settings for pediatric patients. We know that NORA is a challenging issues. We really face it. We have been doing a lot of radiation therapy procedures, the CT scans, the MRIs, the biopsies, and hence there is variability. We may not have a standard practice, guideline-based practice because they have so much of variability. And this article will make us understand the various techniques that various anesthesiologists have been using across different places and probably will give us understanding. And same is associated with many others letter to editors, interesting commentaries, where we really find and understand the importance of again the teaching where we talk about 1 minute perceptor model. We also talks about another common flexor plane block. We also talk about deep rector sheath block. We also talk about the intravenous cannulations, the vascular compromise and its effects on ECGs, and we also talk about the drug like somagondax. So a lot of information, Amrita. People will have good
Yeah.
understanding, and it will be something for each
Yes, sir.
enthusiast across various fields, whether pediatrics, regional anesthesia, cardiac surgeries, everything will be there. Thanks to the authors also who have submitted their hard work, and I'm sure that this will improve their outcome looking in those studies.
Thank you so much, sir, for the insight. So, before we wrap up, any sneak peek into the upcoming special issues or initiatives from IJA?
Absolutely, I think we have, as I mentioned, that the fascial plane blocks is becoming glamour of the day. So people are looking for. I do not know whether anesthesiologists have in the past looked for started from the plexus first, and then they were looking for nerves tracing down it. I think they were totally fed up identifying only the plexus is the nerves, and now they have started looking for planes. So probably, I think this is fascinating, and I could see that every month IJ will get, and the authors will claim a newer facial plane block, and this is every month submission. So I thought, why not to have a special issue where people can share their information on facial plane blocks, And it will be a themed issue fully dedicated to facial pain blocks because we want that this block being effective, appears to be safe, can be used in high risk surgeries, but we need evidence. And hence, this theme issue will try to intake all the facial plane blocks, the original articles, the narrative reviews, the systematic reviews and meta analysis, and technical things. So, I would urge all the researchers community, the SRMAs, that is systematic review meta analysis, will definitely be given a priority for these theme issues. But we also invite good narrative reviews from the experts who are doing exceptional work in facial plane blocks to submit the narrative reviews with good illustrations and graphics so that people also learns it, and definitely the original articles where we will publish in the theme issue.
Thank you so much, sir. So we had a lot many to learn from you and get a good insight about the upcoming issue. So as we wrap up this 41st episode, I wish to thank Professor Rakesh Garg sir for his time, clarity, and continued leadership at the helm of IJA. And thank you, dear listener, for staying engaged with us. Remember, knowledge shared is practice transformed. Don't forget to read the latest issue of the IJ, share your thoughts, and subscribe to stay updated with the upcoming episodes. Until next time, this is Dr. Amrita signing off from the editor's desk. Stay curious, inspired, and stay safe. Thank you. Bye.